Good morning from Dhaka. Indeed, it's a very crazy time and we are at war. But there are fighters and many frontliners. We'll hear from them today. Welcome to the webinar on COVID-19 and frontline responders, health professional perspectives. Center for Governance Studies in partnership with the Queensland University, Australia organized this webinar to bring together the frontline health professionals from Bangladesh, Afghanistan, Nepal, India, Pakistan, Sri Lanka, New Zealand, and Australia. I would like to welcome Dr. Hassan Shohag, Professor Dylan Claus, Dr. Mark Chiggins-Pass from Australia, Ms. May Villamoor, and Dr. Deborah Harris from New Zealand, Mohammad Wais Nagdad from Afghanistan, Dipti Bisht from Bangladesh, Dr. Sulfi Nuhu from India, Dr. Sungita Misro from Nepal, Dr. S. Mathangan from Sri Lanka, Dr. Hassan Aurangzeb from Pakistan. They are our today's panelists. I, along with Emeritus Professor M. Adil Khan and Dr. Rebecca E. Olson, will moderate the event. Professor Linda Cheshire, Head of the School of Social Science, University of Queensland, Australia, and Ms. Adriana Alberti, Head of Capacity Development Unit, Division of Public Institutions and Digital Government, United Nations Department of Economic and Social Affairs, New York, USA, will deliver the welcoming statements. Please do turn off your microphone until you are asked. First, Professor Adil Khan will deliver the objectives of the webinar. Professor Linda Cheshire and Ms. Adriana Alberti will deliver their welcoming statement. Then the panelists will be asked to share their experiences. After that, there will be a question and answer sessions, and then the webinar will be summarized and closing remarks will be delivered. And now I would like to invite Emeritus Professor M. Adil Khan to deliver the objectives of the webinar. He is a Professor of Development Practice, School of Social Science, the University of Queensland, Australia. Professor Adil Khan, it's your turn.
Thank you, Mr. Zillur Rahman, for inviting me to present the objectives and the expected outcomes of this webinar. Before I do that, let me send my greetings to all those people who have organized this, the Center for Governance Studies and the University of Queensland Faculty of Humanities, Arts and Social Science and School of Social Science, and all the panelists who have so kindly agreed to join us, and indeed all the participants and attendees who would be also participating with us. This particular webinar has a bit of a background, like we have been working hard towards this challenge that we are faced with. We need many experiences to learn from each other. So that's the main backdrop. And the reason we focused on the health responders, particularly at the front line, is because they provide the major insight into the dynamics of this challenge that we are facing and the kind of approaches we should be taking. And one way of doing that would be to learn from each other. So if, let me see whether I can work on my, let me see whether I can share the screen. It said host disabled participant screen sharing. So I can't do that. So Zillur, can I share the screen, or it said it's disabled?
Yes, you can.
Screen sharing.
You can.
Okay. So if I go through this, so by bringing together the Asia Pacific frontline COVID-19 responders, policy managers, and researchers, what we're aiming to achieve are the following: facilitate cross-cultural learning of successes and difficulties encountered by the frontline responders in treating and handling COVID-19 patients.
Not appropriate. No, the headphones should not be shared.
And appreciate, somebody needs to mute that microphone. You can hear the other sound coming in. Okay. Appreciate the nexus between the governance, policy services provisions, and service delivery at the front line. Appreciate the emotional and trauma aspects of the frontline responders and importance of support services for trauma management and mitigations. then create opportunities. This is important. Create opportunities for networks and peer-to-peer dialoguing, and also to create a platform for ongoing information exchange for problem solving. And then we'll continue to do our policy research, publication, and information dissemination. So these are the main objectives of this webinar. And the kind of outcomes we expect from it: information exchange, as I mentioned, lessons that we learn, and also what do we do from here? Where do you go from here? So in terms of follow-ups, the immediate follow-up would be, we would summarize the lessons that we learned from today's conversations and bring out some sort of a policy advocacy paper, which we'll share with everyone. And medium to long term, we will try to facilitate partnerships and networks for sustained peer-to-peer information exchange for best practices learnings and applications at the same time, and continue to do our research and publications. So thank you. That's what summarizes our objectives and follow-up parameters for today's webinar. Thank you, Zelur.
Thank you, Professor Adil Khan. Now I'd like to invite Professor Linda Cheshire for delivering her welcoming statement. She is the head of School of Social Science, University of Queensland, Australia. Professor Linda Cheshire.
Thank you, Professor Rahman. I'm delighted to have the opportunity to welcome you all to this webinar today, wherever you may be in the world. And here in Australia at the University of Queensland, we're meeting on land that is not ours, and I'd like to pay my respects to the traditional owners and their custodians of these lands on which we are meeting here today in Australia. I pay my respects to their ancestors and their descendants who contribute to cultural and spiritual connections to country, and I recognise their valuable contributions to Australia and global society. This event today is proudly hosted by the School of Social Science at the University of Queensland in partnership with colleagues from the Centre of Governance Studies in Dhaka, Bangladesh. In particular, it's the result of a great deal of work and planning by Professor Zilla Rahman, the Executive Director of the Centre for Governance Studies in Dhaka, Honorary Professor Adil Khan, Professor of Development Practice here at UQ, and Dr. Rebecca Olson, one of UQ's leading social science health researchers. And as we already know, we have speakers from 8 countries around the world: Afghanistan, Australia, Bangladesh, India, Nepal, New Zealand, Pakistan, and Sri Lanka. And that's a terrific achievement. I welcome and thank each one of you today for their important contributions and insights. The Centre of Governance Studies is a new collaborative partner for UQ, but it's already becoming an important one, and I hope our work together continues and deepens. Good governance, global security, social justice, and citizens' rights are critical components of the development of a safer, more inclusive and equitable world. And universities as sites of scholarship, training and research have a profoundly important role to play in promoting these outcomes. We reveal through critical thought and empirical research where and how inequality continues to exist. We understand the structural basis of inequality and its effects, and we're able to foster creative solutions for a better future. In this sense, both UQ and the Centre for Governance Studies are embedded within a global network of institutions who are working to achieve these goals. One of the most significant of these institutions is the United Nations, and I'm delighted to welcome Adriana Alberti, who heads up the Capacity Development Unit in the UN's Division of Public Institutions and Digital Governance, for attending today. And I think we're all well aware that Adriana is joining us from New York at an inconceivably awful time. So thank you, Adriana, for taking the time to support and attend today's webinar. The time and location of today's events are quite fitting. At present, UQ is leading a team of researchers who are working around the clock to develop a vaccine against the COVID-19 virus. UQ has entered an agreement with the Coalition for Epidemic Preparedness Innovations, otherwise known as CEPI, and the Australian-based global biotech company CSL Limited to support the clinical trial and industrial scale manufacturing of an additional 100 million doses of the vaccine towards the end of the year. And importantly, under the agreement, CEPI's vaccination allowance will be distributed through the COVID-19 Global Access Facility to ensure that we have global distribution of the vaccine so that no one and no country is left behind in the fight against COVID-19. Human trials of the vaccine commenced in mid-July with 120 volunteers, and the trial will be expanded to a broader demographic if successful in around 3 months. But the clinical response to COVID-19, as important as it is only one part of the story of the global pandemic. And as our speakers will outline today, the health costs of the virus have been shouldered and mitigated by the extraordinary effort of frontline health workers. These workers have placed their own lives at risk to save those of others, and it's time for us to hear and pay attention to their stories. That we do so now as second waves of the virus become apparent around the world reminds us that this pandemic is severely testing our resilience, our resources, and our governance systems. Here in Queensland, where we've inadvertently progressed towards a path of elimination, life has some semblance of normality. But elsewhere in our country, the battle has been resumed, and in many parts of the world, that same battle is ongoing. Our frontline workers have by no means finished their work. Their practices are constantly evolving and improving, but their personal capacities risk being depleted. And this is where social science researchers have a role to play in outlining the institutional, the social, the relational, and the emotional dimensions of the COVID-19 health response. While UQ microbiologists advance their clinical response to COVID-19, UQ and the rest of the world's social science researchers draw on their knowledge and expertise in professional practice and the emotionally laden nature of caregiving to highlight, support, and respond to the structural and individual needs of health frontline researchers. Today's webinar not only gives us the opportunity to showcase this important work, but also to foster a global conversation and a new set of research collaborations and opportunities in the areas of health policy and crisis management. I look forward to hearing from our speakers today and seeing where this conversation takes us into the future. Thank you.
Thank you, Professor Linda Cheshire. Now I would like to invite Ms. Adriana Alberti to deliver her welcoming statement. She is the head of Capacity Development Unit, a division of Public Institutions and Digital Government, United Nations, Department of Economic and Social Affairs. Ms. Adriana Alberti, floor is yours.
Thank you very much. We still are battling also technologies. They're wonderful, but sometimes, so I want to thank you very much and congratulate the organizers for this very timely event. It is a great pleasure for me to join you in this webinar. And in particular, I wish to thank the School of Social Science and Faculty of Humanities, Arts and Social Science of the University of Queensland in Australia, and the Center for Governance Studies in Bangladesh, especially Professor Adil Khan of the University of Queensland, who is also a former colleague of mine at the UN. I also welcome the distinguished panelists of Australia, New Zealand, and South Asia, who are also the frontline responders themselves. As you know, the COVID-19 has emerged as an unpredictable complex crisis. It is affecting all countries. However, developing countries will be the most impacted. The outbreak is also disproportionately hitting vulnerable and marginalized groups. The people in developing countries are for over 50% still employed in the informal sector, particularly women, who also have less access to social protection, are the most vulnerable. The pandemic has created major disruptions to the functioning of governments as a whole and the provision of basic services. It has exposed deep inadequacies in the existing systems and inequalities within many societies. It has uncovered governance weaknesses and capacity deficits in the health systems. The current pandemic has challenged governments as usual as a whole, not just in developing countries as we have seen, but in many developed countries that are struggling around the world. Yet, despite the many challenges, and this is why I think this webinar is so important, to bring together the voices of all the first respondents, we have witnessed in every corner of the globe the courage, dedication, and the relentless efforts of the frontline workers, especially in the health sector. Doctors, nurses, paramedics, and all those who are working to help people affected by COVID-19 have demonstrated the value and virtue of public servants Without their solidarity, commitment, and care for others, we would be in a much worse place today. I would like to echo the voices of millions of people from around the world and thank them for their precious contributions to the well-being of our societies. The health workers taking part in this webinar today are an inspiration to all of us. Every year on 23rd June, the UN celebrates the achievements and the hard work of public servants through what is called the UN Public Service Day. On that occasion, we also hold the UN Public Service Forum to exchange knowledge on innovative practices and to promote peer-to-peer learning. We are also working closely with schools of public administration to produce a curriculum on governance for the Sustainable Development Goals, which will also include modules on how to equip the public sector with the capacity to face similar pandemics in the future. I believe that this event will be very relevant as it offers the opportunity to hear from those who have been battling on the ground every day. Their voices must be heard and can add tremendous value to our discussions on how to strengthen public institutions and improve public services, especially health services. I am very grateful to Professor Khan for materializing the idea he had shared with me a few months ago to listen and learn from the perspectives of health workers to gain insights for our capacity development work. He then engaged his university, the University of Queensland, and the Center for Governance Studies in Bangladesh to make the event happen, bringing together frontline workers from Australasia and South Asia. The spirit of sacrifice and selfless acts of these frontline workers must make us reflect on the value and importance of solidarity, not just in times of crisis, but also in the future. Indeed, this crisis calls for a deep reflection of what type of communities we wish to live in. For this to happen, governments and people will need to rethink what a good society looks like and the values upon which our societies and social contract are built. We must ask ourselves, is it a society where healthcare is do we want to live in a society where healthcare is a privilege of the few? Is it a society with deep inequalities and precarious living conditions for millions of people? Is it a society where a few reap the benefits of our collective efforts? Individualism, inequality, disregard for the well-being of vulnerable groups, disrespect for the environment, and the primacy of economic gain over social and environmental dimensions of sustainable development have made this crisis much worse than it could have been. At the end, the quest we must address is, how do we want our societies to be governed? And this really depends on the values and the principles upon which we want to build our societies, taking advantage of this crisis. So events such as this webinar gives us the opportunity to reflect and promote dialogue that brings governments together, frontline workers, scientific community and academia and civil society to find ways towards a better future. I also want to highlight that the 2030 Agenda for Sustainable Development and its principles of leaving no one behind and intergenerational equity are more valid today than ever before. The agenda provides a path for countries to build back better by focusing on global solidarity, inclusion, social protection of vulnerable groups, and respect for our environment. I wish to thank once again the organizers and frontline responders for organizing and participating in this important event, particularly the Social Science School and faculty of the University of Queensland in Australia, and the Center for Governance Studies in Bangladesh. I wish you all a very fruitful discussion, and I look forward to your insights, recommendations, and to fruitful continued collaboration. Thank you very much for your attention.
Thank you, Ms. Adriana Alberti, for your welcome statement, valuable statement. And now the second part, to facilitate this part, I'd like to invite Dr. Rebecca Olson. Dr. Olson is a senior lecturer in sociology, School of Social Science, at University of Queensland. Dr. Rebecca Olson.
Thank you very much. So I'll be moderating the presentations from our frontline responders from Australia and New Zealand. Some of the presentations will take a very standard presentation format. Others will be more of a conversational format. So I'd like to start by introducing Dr. Hassan Shohag. So he's a staff specialist in internal medicine at the Gold Coast University Hospital. Hassan was among the very first doctors, if not the very first in Australia, to treat a COVID-19 patient. So I'll start, Hassan, by asking about your first engagement with COVID-19 patients.
Thank you very much for inviting me in this webinar. I'd like to thank Dr. Khan and also thank Rebecca for sort of giving me the opportunity and sort of telling me and showing me what sort of goal we are after. To answer your question, the first engagement, as you know, the Gold Coast is sort of has got a movie set. It has the Warner Brothers movie set, and then many actors from Hollywood comes here for shooting. Actor Tom Hanks and Rita Wilson was shooting in March when they got sick and they got admitted to our hospital, Gold Coast University Hospital, and they were found to be COVID-19 positive. So that was the start of the whole journey. Immediately our hospital went through a restructuring. My department, which is the internal medicine, was put in the front line. So the consultants were the leader of that front line, and we were working as in rosters in 2 weeks slot. My first direct engagement with COVID-19 positive patient was around 4th week of March 20.
And what about the specific kind of steps or structures that were put in place at the Gold Coast University Hospital to ensure that kind of handling and treatment of COVID-19 patients at the hospital was efficient, and to think about the spread within the community?
Obviously, it was really, really new for our hospital. So, but they did a very good job. So what they did is first they established an executive team. And this teams are members which are selected from different departments. Basically, the head of the departments were there, and also the executive bodies. The main role of this team was the planning at the government, community, and hospital level. The leader of this team usually were and is, of course, infectious diseases and public health teams. So I'm not involved in this team, but I could see what they have done. So they have restructured the hospital. They have opened a COVID team, obviously, which is us. And then they also made a community COVID team. And then they have opened hospital COVID wards, fever clinics. Then I also know that there is a virtual clinic and hospital in the community, which was made by them. And that they have ensured a specific entry point and exit point of the COVID patients in the hospital. They also instructed ICU to make a dedicated COVID-19 patient area. Rebecca?
So I think you've already started to talk about this next point. But I was wondering if you could elaborate on the ways that you in the hospital considered the security and safety of doctors and nurses.
Yeah, as you know, we already know that COVID-19 is very, very contagious disease. So everybody was a bit anxious about it. But hospital has taken adequate steps for the safety for the staff, not just the doctors and nurses, all the other staffs, including like the allied health, cleaners, ward boys, and etc. etc. So the main things they have done is the COVID wards, obviously, which are like no man's zone other than the COVID patient, entry exit points for the COVID patient, transportation protocols for the COVID patients. And we had specific investigation protocols for them as well. We tried to put all the COVID patients in negative rooms or a single rooms and hospital has ensured appropriate and adequate PPE and also adequate sanitization. We are currently maintaining strict social distancing and also to minimize the workload on the doctors, nurses, and the others. The duties were broken down in shifts. All the routine surgeries were cancelled. Some of them now started doing it again. And the junior doctors who were involved in those wards, in the surgical wards, they were moved to the COVID duties so that the pressure is not that good, not that bad. And then we also had daily briefing and multidisciplinary meetings for evaluation of the process and also to see whether there's any fault in the system.
What about the emotional stress associated with health work? What specific steps did the hospital take to address the emotional stress and trauma of this kind of health work?
Look, my experience with COVID cannot be compared with the rest of the world because we did a very good job, as you know. We are well prepared. Management of the patients were well executed. We never had to go beyond our capacity. And so I can't actually really say that I had gone through any physical and emotional stress due to COVID itself. But if it is needed, we are fortunate enough that we have a program called Always There Peer Support Program. This is in Gold Coast Health, and it provides emotional and practical support by a trained peer. We also in Queensland Health has an employee well-being program. Through this program, the health employees can access social, emotional, physical, financial, and workplace well-being support. And
were there any other kinds of issues that caused stress or trauma specifically for you?
Look, it's not related to the hospital itself. Obviously, a few of my friends were also in the front line. One of my friends who was working in UK, who graduated from medical school with me, he was a urologist, actually unfortunately died from COVID infection during the same period. It was really extremely stressful for me and for my family because they were a very close friend of mine. And also added to that as well, I was seen as a bit differently in the community because I was in direct contact with the COVID patients. Few of my community members also said, why don't I just stay in the hospital and not come to the community, because they looked at me as a potential threat for COVID infection. And it was also very sad that I had this same sort of impression from one of my colleagues. So yeah.
And what was your overall impression of the handling of COVID patients at your hospital?
Look, I'm glad that I'm a part of this because the pandemic historically happens possibly once in a 100 years time, and I never felt threatened or helpless because I could see my hospital is really well prepared. And till date, there is no death reported from COVID-19 from our hospital. So I was not really afraid or shocked by COVID at all. And I believe the success of Queensland dealing with this COVID till date has been due to good leadership, community public health measures, and wide availability of the testing. As you know, that we have already tested more than 500,000 till yesterday. And also early proactive measures from the hospital system.
Thank you, Hassan. So let's hear next from Mark Zegenfuss, who was really instrumental to those early proactive measures. So I'll introduce Associate Professor Mark Zegenfuss, Chair of the Statewide Intensive Care Network and Deputy Director of Adult Intensive Care Services at the Prince Charles Hospital in Brisbane in Australia. Over to you, Mark. I'll start with a question about the feeling on the ground when people were first becoming aware of COVID-19. How did you respond?
Thanks, Beck. Look, so obviously there was a feeling of uneasiness, especially in the intensive care community, because at that point in time, the internationally sort of quoted ICU mortality was between 50 and 90%, or 88% to be honest. So there was a lot of anxiety. And we also get a lot of news from overseas about healthcare workers in ICU becoming infected for a variety of reasons, be it because of lack of PPE, be it because of fatigue or things like that. So there was a generalized sort of feeling of anxiety, but as we started preparing, you know, that anxiety level got relieved. And that happened because we had a targeted sort of effective, very visible leadership team that was trusted because it incorporated a lot of clinicians, not just administrative staff and bureaucrats. So it had frontline workers there. So that was an important thing. We had consistent messaging. And look, we try to accommodate for the lowest common denominator. And whether that is a cleaner in an ICU or a nurse or the person delivering the food or whatever, everybody's anxieties would be sort of accommodated. Then from an ICU point of view, I was also involved at the statewide level. So at trying to prepare an area which is what 1.8 million square kilometers with 5 million people for this potential, and at that time disease that had a lot of translation into ICU. So one of the things we did is we created a centralized purchasing sort of framework. The reason is all of the ICUs were chasing the same resource, right? Everybody wanted a ventilator, everybody wanted an infusion pump. 23% of the patients require dialysis. So everyone was chasing the same resource. So what I went out to every single ICU and asked them to draft me requirements, for them to run at 100% capacity, then 150 or even 200% capacity. And we tried to obviously purchase equipment towards that, but like everybody else in the world, there is problems with supply chains. And I kept the anxieties of problems with supply chains at my level and didn't feed that down, because there's absolutely no sense in other people fretting about something that they can't do anything about. The other thing is that I divided Queensland up into intensive care clusters. So what that means is that I grouped ICUs with certain clinical capacity and capability to other ICUs, so that once we would get overwhelmed, and we have flattened the curve quite nicely, once we would get overwhelmed, that these people would know who to lean on next for support. And the important thing is that you plan your strategy on COVID, which, by the way, will be with us for years to come. So there has to be endurance in this. There has to be sustainability, scalability, and flexibility in this, is that you have the little guys supported by the bigger guys. One of the other ways that we did this is we quickly developed a video conferencing facility, so that somebody in a small town with, say, 500 people out west in Queensland, if they wanted to, in the middle of the night, they could call a senior intensivist in one of the bigger units to get support on, for example, treatment or triage and things like that. The other unfortunate thing that we had to do very early is say, well, what if we do get overwhelmed? Who gets into ICU and who does not? So we engaged the community and ethicists and legal entities very, very early, and we drafted a document about who would get access to a limited resource. And I do know that this is something that the politicians don't like a lot, but it is a necessity. A resource-limited environment warrants rationing. So how would we ration? And what we looked at is obviously the comorbidities and the risk factors of the non-survivors overseas. Now, having said that, overseas, the ICU mortality rate, if you look at the latest ICNOG report from the UK on Saturday, still sits around 50%, right? That's still pretty high. whereby we have been fortunate enough in Queensland with our small numbers to run, around 5% or something like that. So, but what that shows is that if you can work in an environment that is not stressed, the staff are not stressed, you've got enough resources, you admit the right patients, etc., you can get good survival rates for COVID. All right. One other thing is that I would strongly advocate for is having reusable PPE, because PPE is in worldwide shortage. And very early on, I try to focus on people taking on a PPE and drug preservation sort of modus operandi, because we are only at the beginning of this pandemic. So look, I mean, what I can say is that, look, when I treated the first patient in my ICU with COVID, it was very surreal, because you're stepping into an environment that, as an old intensivist, it could it could do you harm. But the bottom line is that is that you make sure, and to me, the way I look at this whole COVID response is to minimize the impact that it will have on healthcare workers. We just heard from Hassan that he was chastised in the community for coming out, said, why don't you just go and quarantine yourself and stay in a hospital? We had nurses who were walking in nurses' uniforms in the community being scolded and verbally abused. So that is just lesser-minded people not understanding what you're doing, and you've got to just focus on that. Because one other thing is that we saw an escalation of domestic violence in Queensland with the lockdown, and obviously I'm South African, and obviously you can see that communities like South Africa, or like it will happen in Bangladesh or wherever, there's a huge psychological impact which you need to prepare for now. But just as a closing word, one thing I would say is that is to quote Gandhiji, who said, you measure a society by how it treats its least fortunate. And we are in this together as a global community, and we should not have geopolitical borders, interfering with networking like this, or even with resources. But we'll talk to the politicians about that. That's all I'll say for now.
Thanks so much, Mark. That was very thorough and very insightful. You mentioned nurses being abused in the community. I think it might be time to hear from one of the nurses on our panel, May Villanueva. So May is a registered nurse. She works at the Auckland City Hospital in New Zealand, and she has treated COVID patients there. I believe it's 6 since the pandemic started. So over to you, May, to tell us about your first engagement with COVID-19 and what that was like.
Yeah, it was, again, I am a nurse in, formerly it is general medicine ward, infectious diseases. But since this pandemic, COVID-19 has already come, then we were restructured to be COVID ward. It is like similar restructuring from what had been mentioned a while ago. Like we have been isolated from the other wards. Our lockers, we have our own lockers, our own restroom, and we have our own cleaner, our own team. And there is already a COVID team that consists with all COVID nurses who are just very exclusive in our COVID ward. And at first, handling with the first patient, I thought that it would be in the respiratory ward. However, I was just so amazed that it is in our ward, because the first restructuring was all the COVID patient confirmed cases will be in the respiratory ward, wherein there are 7 negative pressure rooms. This negative pressure room, just for lay term, is that this can, like, when you have your sneezing, I mean, and then it will not reach you right away, and it will be like dissolve on the air. That's why it's called negative pressure room. So going back is that I thought it will be there in respiratory ward, but then again it's gonna be in our ward. So it's very nervous. I'm very nervous with I'm full of anxieties working there. I feel like quitting my job already. Like, I'm risking myself and I'm risking my family. It's very hard for me and tough emotionally as a mom, as a mother, that I have a kid at home, that I can be a carrier to them and to my husband. It's very emotionally tough for me as well, because for almost 2 months that I have been managing COVID patients, it's not easy, like looking at them, just seeing them, like literally seeing them without hugging them, without kissing them, and not able to, talk very in a distance. We are just like showing love in a distance. We have been doing video chats. How can imaginable that be, that you are just seeing your faces in the screen, and because you are just in the same home, but you are just seeing each other in a screen. So it's very difficult for me as a frontline and us being part of my family at home. So the strategies that we have done, I mean, my coworkers for my coworkers feeling the same anxiety, because they have also been they have their families at home as well, and it's very tough as well. And we are on the same bubble, like we are interdependent of each other. We are of the same bubble. So if in case that there will be like COVID-19 in any any one of our bubble, then we will gonna be all in the same page. So that was very difficult as a frontline. Yeah.
Thanks, May. What measures were particularly helpful to you in the hospital and in the community? What should we kind of emphasize? As we just heard from Mark, we're likely to be in this pandemic for the foreseeable future. What should we emphasize as we see the second wave or third wave come about?
Right. As a community, the first thing that has been helpful to the healthcare system of New Zealand is the early lockdown. But of course, it's the strategy of each country then. But what we have been using in the hospital is the buddy system. The buddy system is like you have your co-nurses with you while doing the donning of the PPEs, the personal protective equipment, that there will be a COVID form monitoring sheet that is on the door, that before you do your donning, there will be one nurse who will label the date and time, your designation and name as well, and the time that you enter the room and the time that you're going to exit the room. And this has been helpful because we are doing the system because we want to eliminate the spread of the virus, the spread of this disease with our team. So that was the most helpful thing that we have done. And say, for example, this also buddy system helps us. Say, for example, we are administering medications on the patient room. In the patient, we have direct care with them, and then they will ask for a cup of tea. And what we're gonna do is like write a note on the door saying that can I have a cup of tea. In this way we are eliminating frequent care. I mean frequent touch with the patient. And also to conserve PPEs in the hospital. So in this way as well, like whatever, if the patient needs more necessary medication in the time, during the time, then your colleague, your buddy will gonna be with you to assist in the care. So you are definitely like two nurses assisting in the care. So one is like for a watch, and then before you exit the door of the patient, then they will be the one to see that that's not the right thing. Okay, like mask first before going, you know, like that. Like there is a proper sequence, and that must be really abided.
Thanks so much, May. Let's hear next from neonatal nurse practitioner and nursing lecturer, Dr. Deborah Harris, who was part of the initial team who set up the National Close Contact Service in New Zealand, capable of calling 10,000 people a day for contact tracing. So Deborah, can you tell us about that National Close Contact Service and your role in setting it up and seeing it start?
Kia ora
from Aotearoa, New Zealand, and thank you very much to Dr. Khan and to Rebecca for inviting me to take part. It's fantastic to be part of such an international forum and to listen to everybody's discussions. For me, I was asked to go into the Ministry of Health to help set up the National Close Contact Service. And when they asked me, they said it'll only be for 3 days, Deb, and I was there for 3 months. So, and the reason that we needed to have a national response will be obvious to us all now, but before that time, what was happening is our public health units, of which there are 12 in New Zealand, were all managing it independently. And so there was a ministerial decision that we needed a national response to do that. I was called in on the 18th of March, which was when we were having our biggest and only really big outbreak in New Zealand. The people that were there that were asked to go in, there was me and 4 other senior nurses, and we worked with a variety of professionals, of course, public health physicians, but also data managers, people that could help us gather data quickly, people that could help us develop what is now called the National Close Contact Data Solution, which is a database that collects every single piece of data about a COVID patient in New Zealand and also close contact patients in New Zealand. And you can access that information if you're in a hospital, if you're in an ED. So we have got a national service now. So you can imagine the number and the caliber of people that were involved in setting that up. We began calling people on the 19th, so the day after at 5 o'clock in the afternoon, and the goal was to develop a close contact tracing system that could contact people within, initially it was 48 hours of the diagnosis, and now it's much, much shorter, 24 hours of the diagnosis, and ask them to, the words were self-isolate because that's what the media was saying, but for those of us in public health, we know that for people that are well, in fact the word is, well, certainly in New Zealand, quarantine. So there, one of the things that we did deal with quite a lot in the public space was getting the definitions and the wording consistent, and we had very clear guidelines and consistent communication, which I think has really helped us in New Zealand.
Thanks so much, Deborah. How did you feel contacting so many people about COVID-19, and how did people respond?
So that's a really interesting question because the voice of the public changed over time. Initially, people were very, very anxious because, and people were saying things like, it feels like we're going to war, but we can't see the enemy. So there was, we had to give a leadership style that was clear and calm and consistent the whole time in order to enable people to do what we needed them to do, which was self-isolate. There were times that I also felt anxious, and there were times that I was mopping up tears of my colleagues. I listened earlier about the death of a close colleague, and that certainly happened in the team that I was in too, with a nurse in the UK dying, who was a colleague of a friend of mine. So it was very real and it was very, very raw. And I think the thing that people are dealing with now, particularly in New Zealand, is something that's already been touched on, is how long we're going to be dealing with this for. I mean, this is a marathon, not a sprint. And we were saying that within about 2 weeks of being in the Ministry of Health, setting up this service, which this is going to be with us for years and years and years. And so we need to be resilient and look after each other and look after each other nationally and internationally.
Thanks so much, Deborah. So our last speaker is from Australia, from the Australia-New Zealand portion of the webinar. I'd like to introduce you to Associate Professor Dylan Flaws. He's an Associate Professor at QUT, Queensland University of Technology, and a Psychiatry Advanced Trainee at the Royal Brisbane and Women's Hospital. And he's head of a mental health research and the critical care research group there. So he was quick to respond to the growing mental health challenges, which Deborah has just touched upon, associated with COVID-19. So Dylan, leading up to the first wave in Australia, what did you observe and how did you respond?
Thanks, Rebecca, and thanks for inviting me to be part of this webinar. It's a great opportunity. Yes, I was in quite a unique situation at the time that the pandemic first rose, in that, as you say, I was a psychiatry advanced trainee, but doing research with a number of critical care clinicians. And it became very clear to me that there was this kind of rising level of distress, especially as the first cases started to emerge in Australia and the reports were coming from overseas. And there were some calls that were coming for the mental health department to provide some support to the well-being of their critical care colleagues. And so I took that request to our local department, and we started very quickly working on developing a support system. So that's kind of the main thing that I've been working on during the COVID pandemic. And as part of that, as well as reading the literature and trying to find what would be most useful that we could do for our colleagues, we also sent out a survey very quickly through the Critical Care COVID Consortium to see what was happening around the world and the ways that people were trying to respond to that. And this was something we did not as a research level, but really to just try and develop something very quickly. And so over about a 4-week period around April to May, we sent the survey out. And I just thought I'd quickly talk through some of the results that came through from that. So I'll just try and share the screen here. So some of the accounts that were being described by the intensivists that I was working with are quite similar to what some of the people have already discussed on the webinar today, where there was a concern about what was coming. There was seeing people becoming unwell overseas, what was going to happen to themselves and their families. And what was observed is that caused kind of anxiety at work. If there was an existing bullying culture in the workplace, that seemed to get a bit worse. There was a little bit more aggression, that kind of thing. And so we sent out this survey. We got 95 responses. As you can see, there was an overrepresentation from Australia and New Zealand. And we also
Dylan,
yes?
Sorry to interrupt. I don't think your share screen has worked. Can you try again? There we go.
Okay, that's working now. So I'll just go back to that previous slide. So
yes.
We had an overrepresentation of respondents from Australia and New Zealand. Australia and America. And we also had an overrepresentation of medical and intensive care staff. We were really interested in anyone that's working in any kind of critical care workspace. What they described was that before COVID, morale generally was pretty good in their units. And most of them were either at or under capacity at the time that they completed the survey. But despite that, distress was actually already relatively high. We asked them to just describe the top 3 things that they were concerned about in their workplace. And I'll just talk through a couple of the most common responses. So the first one was staff resources and capacity. So this was things like, are we going to be able to maintain a good quality of care for our non-COVID patients if there's a sudden surge in cases? What are we going to do if staff start to become unwell? How are we going to maintain good workloads, but also make sure that that's sustainable? Questions like that. The second was PPE, personal protective equipment, and they discussed already that, are we going to have enough masks? Are we going to have enough gowns? Are we going to have enough gloves? And that kind of ties into the next one, which is, am I going to be at risk at work, or is my team going to be at risk at work? And this kind of preparation anxiety. So I can't actually do anything more at the moment. And then next was the other material resources that weren't PPE. So that's things like, do we have enough beds? Do we have enough negative pressure rooms? Do we have enough endotracheal tubes to do our intubations? And overall, the staff felt that they were being at least somewhat supported by their colleagues in this process of keeping each other in the fight and keeping each other in a state of well-being. And the main ways that they found they were promoting or coping was, first of all, peer support. So this is something people have mentioned before. What that tends to mean is that someone else in your workplace, usually working in a similar type of job as you, provides some support to you emotionally, whether that's in a formal or an informal capacity. So that could be the corridor conversations about how you're going, or a coffee or a beer after work, or it could be something a bit more formalized that's been supported by the service itself. Next is communication and teamwork. And again, you heard Dr. Ziegenfuss kind of describing that this is something that people were very keen on. So this is keeping up to speed with what's happening internationally around this, as well as things like group huddles, talking about what worked well yesterday, how we're going to approach it today, how we're going to make sure to make the most of our resources. Third is staying informed. So as this is a shifting beast, this condition, and also the policies were shifting quite regularly, so making sure that they knew what was happening around the world and what was happening in their own hospital. Unfortunately, the next most common was nothing. People felt like they didn't have enough things that they could do. So I've just provided a couple of specific quotes here. Laughing, talking, supporting each other, and a formal peer support program and regular information sharing. Or not much, to be honest, we can't socialize, we can't hang out, and that used to be the main way that we would then to cope. So you can see how some of the community protective measures were actually eroding some people's usual coping strategies. The strategies that they felt the service was implementing, so this is kind of hospital down or executive down. The most common response, unfortunately, was none or not enough. With the second most common being, again, things that I think it was Dr. Ziegenfuss was describing around having regular communication. This is what's happening in our hospital. This is how we're responding. And then training, education, that donning and doffing of the PPE, how to deal with this virus. And the third was rostering. So these are all things that we've actually heard in this webinar already. Having a way that people are going to be off site for a while, back on, and that kind of thing. And then the next few are having an actual psychologist that staff can talk to, a formal peer support program, some kind of relaxation activity at work that they can access, or some kind of well-being officer. And so here's some quotes. Lots of meetings, nothing in particular yet. We're waiting for the service to provide something. Training and education around how we use the equipment. And this was actually my favorite, was, first of all, we've been through worse. We've survived this kind of thing before, and having at least one dose of Billy Connolly's swearing skit at least once a day. The survey is actually still live, and we're still interested if there are any critical care clinicians that are listening in. We would be very interested to hear what's happening at your service and the ways that you're trying to cope during this.
So to finish off our portion of the webinar, Dylan, I'll just ask if you were to do it all again in terms of setting up some support for frontline responders, what would you do differently?
I think the first thing is we were on the back foot with this one, because the condition has an asymptomatic period, and it took a while for the fact that there was a problem to arise for us to become aware of it. It meant that by the time we realized that there was actually a role for us to be able to support our colleagues with this, we were already a fair way down the track. And so we had to work very quickly to pull this together. If there is a second wave that comes to Queensland and people are already kind of preparing for that because we're seeing this in other states here in Australia, we'd be able to be on the front foot. We've set up a peer support hotline at our hospital where we've got psychiatrists available during business hours for the critical care senior medical officers to call if they need to talk to someone confidentially. We were looking at discontinuing that around August, given that the curve was flattening, but now what we're seeing down south, we've decided to continue that. And certainly that's something that we can pass on to other services if they want to use a similar model.
Thank you so much. Over to you, Ziller.
Thank you, Dr. Rebecca. Now we'll hear from the South Asian panelist. In fact, we sent them a few questions and asked them to prepare their 5 to 7 minutes speech based on those questions. Now I'd like to invite Dr. Sangeeta Mishra to share her experience and opinion. She is from Nepal and she is obstetrician and a gynecologist and head of department, medical superintendent of a tertiary care hospital, also director of a Parupakar Maternity and Women's Hospital. Shangita Misro.
Okay, yeah. So I was working in the eastern part of Nepal, in a hospital called Koshi Hospital. At the time when we heard about COVID, at that time we were actually not very. And the first thing we heard about the COVID from our ministry is around 24th or 44th of January. And then at that time, there was no clear directives from our ministry. So at that time we were just fumbling around what to do. And like I was listening to other participants about how they could get all the supplies for COVID, but for us it was not the case. We had to struggle for the mask, for the sanitizer, and for the PP. So the first thing we did was to start a COVID clinic. So all the patients who come with the fever, we had to monitor all the patients, doing all the with that. But slowly there was issues with the supplies, and there was like huge unrest in the hospital about the fear of COVID, and nobody wanted to do duty. The situation in South Asia and in particularly Nepal, India, it's usually different than other countries, because we have this public and private hospital differently. And the public hospitals were more responsible for the COVID response. So if I could remember back when I sat in multiple meeting with the private hospitals, which they were really very reluctant to do COVID response. At that time, we started doing our stuff as we were the government hospital, and we had a huge responsibility. So I tried talking to the local government and the provincial government. In Nepal, we have 3 tiers of the government. The government, although it's a very new system, but it's not very well dependent, and it's not a very established system. So we are very new to this system. So the major problem was with the funding and for the resources. So I tried to coordinate with the local donors, total NGOs, and then with the central government as well. So we could find a old building which was abandoned, abandoned, and we just renovated that building with the help of provincial government. And with the help of provincial government, we could renovate that building up to 100-bedded COVID hospital in just 15 days. So in just 15 days, with the help of army and with the help of provincial government, the hospital was turned into a fully fledged hospital with oxygen facility. But the main problem was with the human resources. We already had a challenge to run a hospital which was already running, where we could not keep our COVID patients, and we had another challenge to run another hospital where we could give COVID care. So at that moment, it was very difficult for us, but somehow I could motivate all the staff. So my role was basically managerial, where I could start from doing the sanitizers and from the medical staffs, and then even we used the material of raincoat as COVID protection against COVID. Suddenly, on around 17th of April, we suddenly got 17 COVID positive patients, because in Nepal, it took on very slowly. So from first patient was January 24th, and we could get another patient was on 17th of April. And it was all the patient, the problem was that all the patients were from India and who came on a religious tour to Nepal. And it was a sort of very unrest kind of situation, and very much people were saying like these people could bring COVID to our country, why they are here, and there was a social unrest as well. But that was also our responsibility, so we had to even talk to the security forces and the army, so that all these things could have been managed. Slowly, the main problem which I think in our country was the resources and the testing facilities, because we could not increase the testing facilities initially, but with the help of the government right now, we have around 30 testing facilities, and it's going on well. Even the cases have increased. But when I remember when we started, the whole country was in a chaos, and people did what they could, because there was no there was no knowledge sharing, there was no directive. So for me, like, we did the hunting for the knowledge. We could reach out to all our students and even our colleagues who were abroad, the way they were doing managing COVID, and we could refine that to our own settings. So even that experience was like, when we started with COVID, it was really bad, but the results when we at the end, it was all okay. I still remember the way when we were like renovating this hospital, we didn't know like how to do the sanitation facility. There was a problem with the waste disposal, and since this hospital was established in my neighborhood, so I could see all my neighbors coming to me, and even my family, they will just saying that why do you need to establish a hospital in the vicinity of your community? So it was a kind of like social outcast, nobody coming to our house. And then I had to be in isolation. Like, I was staying in the isolation since for maybe 15 days. I was in strict isolation, and then I was quarantined myself for around 4 or 5 months. Like, I was not seeing my family, I was not with like having food with my family. So it was a kind of very stressful, but what I realized, that it was my responsibility, a responsibility which I hold to my society. So I could do that. And at the end, when right now I am transferred to another hospital. So right now I think it's a kind of okay, and when I look at the results, it is quite satisfying. And even in 17 or 18,000 COVID positive patients, COVID infected patients, and they were really doing quite like wonderful job. Government is doing very wonderful job. Only 5,000 patients are right now in isolation, and it's good. The main one problem was in Nepal was with the border, because we share an open border with India. And many of our people, they work in India. So when we suddenly closed the border with India, there was really much difficulties, because people started coming to smaller borders which were not very well regulated, and there was a fear of sudden spread of in the community, because we could not track those patients. So that was a problem in Nepal. But slowly the border was also regulated, and there were we could establish holding centers, and slowly they were quarantined. So right now the situation is much better than we started, and thankfully I could get the support from this local government and the provincial government, as well as local donors, and we could channelize all those energy into one, and that's why we could manage this very. Okay, thank you so much.
Thank you, Dr. Sangeeta Misro. Now I would like to invite Dr. S. Mathangan. He's RHO at COVID-19 Emergency and Treatment Unit, District General Hospital, Chilo, Sri Lanka. Dr. S. Mathangan.
Thank you for inviting me to this webinar. Actually, as you can see, Sri Lanka, we have successful so far in defending this COVID-19 compared to other countries in the world. The thing is, I'm working as a relief house officer in the District General Hospital Chilo, which is the hospital is situated in northwest region of Sri Lanka. So in there, so we had a patient in the actually first COVID case found to be positive in Sri Lanka on 27th of January. She was a tourist from China, 44-year female, and after that, actually for 2 months, after that 2 months, we didn't have any positive cases. And suddenly we found a tourist guide. He became positive on middle of the March. So that also from my region. Actually, I actually live in Colombo, city of Sri Lanka, but I work in northwest region. So they are usually most of the housemates and all those people are from that area. They go to Kuwait, Qatar, and those countries. So when this after January, we had a COVID positive case on March. So on that time, it was actually found to be in the community. So all Sri Lankan, we had a fear, especially the government and health sector. We had a fear that it might go spread into the community very soon, because we can see in the world what's going on in the world. So first of all, our government, it's a multidisciplinary management. So with the hospital staff, doctors and nurses, and then cleaners, minor staff, and especially the tri-forces, Army, Navy. So everywhere deployed to this action. So first of all, our government took the necessary step, that is the all-island lockdown. It's actually, I would say it actually worked in this situation, because we could not able to go beyond the district. Even we can't come out. So that lockdown was there for like 1 month. So that's the positive thing. That's the positive thing to combat this COVID-19, especially in Sri Lanka. So suddenly we can see, so we started to isolate the patients. Like if you see, the main is in northern region, there's a set of positive cases, and western region, there's a set of positive cases. In northwest region, there's a set of positive cases. So we didn't have the community spread among them. So wherever the positive cases found, so they were isolated in that area. So that's a good thing that our government did, I would say. So for me, first contact with the COVID-19 patient, luckily I would say our hospital has the enough supplies, especially PPE, mask, everything. We had enough supply. I would thank to my government for that, because we were so prepared to face this COVID-19, especially in my region. So as soon as these things started to happen, what we did was in our hospital, it's a District General Hospital Chilo, we have made a separate COVID-19 unit. That's just opposite to the hospital. So there will be no contact with the patients. And we had a afraid, because the patients coming with chronic kidney disease or else heart failure, those patients, because they have already, the immune systems are not functioning properly, they are immunocompromised state. So we are scared that if they get these infections, it will be a disaster. So for that, our hospitals, we have different entry points and exit points of these COVID patients. So especially if the patient is coming with fever, cough, sore throat, shortness of breath, if the patient is having those symptoms, we immediately take them to this COVID unit. It's a separate unit that's out of the hospital. There's a proper transportation measures were provided, and everyone was wearing PPE. I'm actually talking about 3 months back. So those times it was so horrible, because I'm the junior most doctor, and my parents, they were so scared because we are going to be exposed to these patients. So as soon as the patient comes, we do the PCR and PCR. But in my country, there are PCR labs, 17 PCR labs are functioning now. So if we do the PCR report in the morning, we could be able to take the results in by afternoon. So if the patient is positive, what we do is our hospital we don't treat, we give the only initial management. And if the patient becomes positive, we transfer the patient to the tertiary care hospital. That's in the National Hospital of Sri Lanka, and infectious disease hospital, which is situated in Angola. Those hospitals are they have the super facilities with ventilators, everything. So as soon as the patient becomes, until the patient's report comes, we treat the patients in our ward. So if the patients become positive, we transfer the patient to this tertiary level hospitals. And then, so like that, we have 36 hospitals, all island in the Sri Lanka. We have 36 COVID treatment hospitals and 17 PCR labs. As of now, we have a confirmed cases of 2,782 cases, which is very, very minimum compared to the world. And we are having active cases of 665, and we had the patients who have recovered from COVID is 2,106. The recovery rate is highest in Sri Lanka. If you can see, compared to other countries, we have 75.7% recovery rate compared to other countries. And we have the deaths of 11 deaths, which was reported for past 6 months, past 5 months. And then another saddest thing happened recently, because Sri Lanka was going very smooth, and after the 1 month of lockdown, we were after that we were able to move freely, because the community spread was minimized. That was in the end of May or starting of the June. So our epidemiology unit and the health ministry, they have confirmed there are no community spread. So this lockdown and everything has become easy. So people were moving and everything. That was happened. Then after that, suddenly from nowhere, like July first week, one of the person in the community becomes positive. So now everyone is like, oh my God, now this patient is positive. Mean we don't know where it comes from, where the patient has gone somewhere in the public markets or supermarket or school. So everyone was so afraid. So on that time, what we did was, immediately we traced the contact tracing was done immediately with the help of the PHIs, public health inspectors, and we did the contact tracing. And we found that she was a counselor. She visits to the rehabilitation center. We have a rehabilitation center for drug abusers and this drug mafias, for those things. We have a rehabilitation center. So from there only she has got infected. So then we suspect this might come from this drug dealing was very in Sri Lanka. It's very nowadays it's very risky, and it's happening now. So we thought it may be come from India. You know, they exchange these things in the Indian border. So that's what our government thought. And after that, suddenly, if we do the PCRs in that rehabilitation center, it become massive positive. Like per day, per day, it was 300 positive cases came. That was on July 10th. That was the maximum COVID-19 positive cases recorded in Sri Lanka in a day. 300 cases. That was in the rehabilitation center Kandagad. So like this, it was happened. So right now, I would say in Sri Lanka is now we are having election on August 5th. So and on that time also the person who got positive on July 2nd week, she had a massive contact. She visited to 40 homes near to my area, near my Chilo area. So we did PCR on them. So luckily they become negative. But only thing, these drug abusers who are in the rehabilitation center become positive, more and more positive. So luckily that was in the isolated area. That's the only good thing that happened to Sri Lanka. And then I would say we didn't have any, personally, I didn't have any mental trauma regarding this COVID-19 because we were well prepared to combat this thing. That's what I say. Because as we can see, we have the different entry point to receive the COVID test. So we are already wearing the PPEs and everything was prepared.
Dr. Mathangan, please make it short.
Yeah.
Try to make it short, please.
Yeah. Okay. So that's what in the situation in Sri Lanka. Okay. Thank you.
Thank you, Dr. S. Mathangan. Now I'd like to invite Deepti Bisht. Ms. Deepti Bisht is working as a nurse supervisor at Evercare Hospital, Dhaka, Bangladesh. Deepti, over to you. So Deepti, just try to fix it. I'll come to you later. Okay. Let's move to Dr. Sulfi Nuhu. Dr. Sulfi Nuhu from Kerala. Kerala is a role model for many of us. Dr. Sulfi is Vice President, Central Working Committee member of Indian Medical Association, Kerala, India. Dr. Sulfi Nuhu, over to you.
Yeah. Okay. So it's a wonderful opportunity to speak about what has happened in Kerala. The Kerala model is extremely famous for its activities for the last 50 years or so. At the moment, Kerala so far is doing a wonderful activity as far as COVID-19 is concerned. We are still fighting against COVID-19. The cases started coming in first week of February from Wuhan. Few medical students came to Kerala from Wuhan, and these people turned out to be positive, and three or more cases. And now, at the moment, we have around 16,000 positive cases as on today, with a very minimal death rate of 0.3% and less than 1% intensive care admission. So, the Kerala is highly, thickly populated, very thickly populated. And we have more than 15 lakh people working abroad, in many other part of the country, many other part of the world. It's a huge challenge. It was a huge challenge, and it's still a challenge. And we did, I think, so far we did a reasonably good performance as far as COVID-19 is concerned. What we did, I'll be very brief. We tried to isolate the patients who came from Wuhan. Definitely, that was the first strategy done by almost all countries. But then, when the people started coming in huge numbers from other countries after a very effective lockdown, as the doctor from Sri Lanka told, the lockdown was very effective all over India and especially in Kerala. And actually, we are really, really proud of our literacy rate. We have a very high literacy rate among all the places in India. Maybe comparable to many other parts of the world also. So we were able to do a reasonably good lockdown, and after the lockdown, the people started coming, and now the number of cases are increasing. What we did is we isolated the patients coming from abroad at home quarantine. So we have around, at the moment, we have around 1.5 lakh people in quarantine at their residences. We have a very effective COVID care centers in the government setup. Also, non-COVID care centers in the periphery and also in other centers. So the people are isolated, and the COVID patients are treated in the COVID care center. Most of them are tertiary care centers, and we have very reasonably good facilities there. I'm working in the government sector, in the government service. Basically, I'm an ENT surgeon. But what has happened is I was forced to read more about COVID rather than my own subject, otorhinolaryngology. So in the last few months or so, that's the case for almost all the doctors in Kerala. So as part of the Indian Medical Association, we try to educate our doctors. We did a lot of activities along with the government. Government did a wonderful job in doing all the treatment care, isolation centers, quarantine, and we have now the first line treatment centers. Now almost all the COVID care centers are almost full, and now we have first line treatment centers in which the positive cases are admitted. And I would like to point out one thing very importantly: we are admitting almost all patients to the hospitals. If the patient is asymptomatic, as the world literature says, it says that almost 40% of people are asymptomatic, and we are admitting almost all patients to the hospitals, and we are monitoring these people at the moment extremely well. We may not be able to continue that if the number of cases increase, definitely, but at the moment we are monitoring all the patients, even if they are asymptomatic, in hospitals. That was one of the best point to point out that we have a very low mortality rate at the moment. We were able to monitor all those patients for the hypoxia or whatever. So along with, as a part of Indian Medical Association, we did a lot of good job. We have a project called IMAGE, in which the COVID waste management is done extremely well. The biomedical waste is managed in a centralized unit run by the association. So we have an iSafe project in which we educated all the doctors and health workers to work in a very safe environment as far as the COVID-19 is concerned. And also we conducted hundreds of webinars. We tried to educate our colleagues. We tried to educate our nurses, paramedic staff, even our bureaucrats. We did workshops for webinars for the government also. And also we are trying, at the moment we are trying to set up FLTC, first line treatment centers, for the doctors if they are going to be infected at the moment. And most importantly, we did give a lot of technical advice to the government. Most of the advices, or maybe the suggestions given by the Indian Medical Association, was accepted by the government, and it is being implemented in Kerala. So that is the short story. It's actually very short story. There are a lot of negatives also there, which are there. In next our neighboring state, Chennai. It has witnessed a very bad situation, very sad situation, in which one doctor was forced to take his friend's dead body to the burial center. Why? Because many people, the mass gathered around the ambulance in which the body was carried. They destroyed the ambulance, and they prohibited. They forced the doctor to go. The driver to go out, and in fact, the doctor was forced to carry the dead body of his friend literally to the burial ground and do the rest of those things. So that is the situation here. So we are hopeful, but maybe the cases will increase definitely because of our very highly thickly populated situation here. So we are trying our level best. So as many people say, we need a cooperation from all the countries and all the states and all the communities across the world. We have to work together. Thank you so much.
Thank you, Dr. Sulfinihur. Let's hear from Deepti Bist. As I said, that Deepti is working as a nurse supervisor at Evercare Hospital, Dhaka. Deepti, what do you? Okay, let's hear from Dr. Ahsan Aurangzeb. Then I'll come to you again, Deepti. But Dr. Ahsan Aurangzeb is a Pakistani neurosurgeon, works at, he is now medical director, Ayub Medical Teaching Institutions, Pakistan. Dr. Ahsan Aurangzeb.
Thank you very much, Zilur Rahman. It's definitely a great pleasure to be a participant in this webinar and seeing all the people from around the world and sharing their experiences. I happen to be the medical director of one of the prestigious institutes in Pakistan. It's in the north of Pakistan, and we cater, it's the only tertiary care facility, and we cater for about 8 million population directly and indirectly. And we have all the relevant subspecialties. So definitely this one thing that I've learned from COVID-19, and I'm sure everyone has learned, that COVID-19 has transformed our lives tremendously. And the one thing that I learned is that we are running after so many things, but COVID-19 taught us the value of life, the value of relationship, and the value of care that we have to know, and the value of humanity eventually. We started receiving the first patient in Pakistan was on the 26th of February in Karachi, who happened to be a religious tourist from Iran. And then ever since then, we started making our preparations to meet up with the challenge of COVID-19. So we established a team involving the public health, the infectious disease specialist, and pulmonologist and interventionist, and the internal medicine. And we set up certain protocols for our hospital since we knew that everything would be coming down to us. We established our triage systems, and we evacuated our dental block, which was connected to our, and we made an isolation department for the COVID-19 patients, and we had some 71 dedicated rooms. We didn't have negative pressure rooms over here, so we created 71 dedicated isolation rooms, which had everything dedicated for one patient. And then we had our medical ICU, we converted into the COVID ICU, which had 18 beds, and along with that, we had 18 ventilators, CPAPs, and BiPAPs. And we engaged our team. Now, definitely the first patient which came to us around the 11th of March, there was a lot of apprehension in the staff because COVID-19 was seeing the figures around the world that we had been seeing what China had gone through, and especially the West had. COVID-19 had brought down to knees all the developed and underdeveloped systems. So it was definitely a challenge for us as well. There was a lot of apprehension, fear, and phobia, how to do with it. So we engaged our team of psychiatrists and clinical psychologists to motivate our staff. And we engaged our media department to run a campaign in the local radio channels, news channels, and our hospital. We made periodic announcements to spread public awareness so as to minimize. And we did a wonderful job in this challenge of COVID-19. We got a lot of patients, and our total number of patients that we admitted were some 1,400 patients that we got for COVID-19 in our hospital, out of which we had about 81 deaths. So our mortality rate was around 17%, and the recovery rate was obviously 83%. But in this all challenging times, we learned that the third world needs to pay more attention to the challenge of healthcare systems, because what I learned from this, that health is what the third world should be more focused on, and education, which unfortunately is not the case in the third world. So once we are over with this, I think our governments and our people should be more concerned about the health system and the future challenges to come, because I think COVID-19 is not going to be over anytime soon. And we are expecting a second surge after this Eid al-Adha, which is going to be celebrated across the Muslim world. And the first surge we had was after Eid al-Fitr, when the government relaxed the lockdown. So definitely we need to focus more on the upcoming times, and we need to strengthen our health systems and the health facilities, so that in the coming years, definitely we might of COVID-19 like situations. We only read pandemics in our syllabus in the med schools, but I don't know what to say, but I've lived one through, and all of you are also living through it. And it has really been a shock for us to see what a pandemic can cause. And it has definitely changed the face of the world and set certain new normals, which are going to be there for the many years to come. Thank you very much.
Thank you, Dr. Asana Aurangzeb. Now I'll move to Dipti Bisht.
First of all, for everybody for considering me for joining this webinar. I'm Dipti Bisht. I'm not going into the details. First of all, my experience for facing the first COVID patient was in the month of February. It was in the midst of February. And we come to know about this patient, that this patient is positive for COVID very later only, unfortunately. But our team was well prepared and we managed the patient very well, and we use all the precautionary measures and the standard precautions as well. About the COVID-19 preparedness, if I want to speak, I will tell that our hospital as well as our government was well prepared. They were having specified guidelines and protocols. And according to my hospital, we are having enough supplies. And we were very well prepared. Different types of seminars and educational training programs were conducted to the doctors as well as to the nurses, as they were the frontline warriors. And coming to the point of the preparedness of the hospital, I would like to tell you that we were having separate triage clinics as well as fever clinics for managing the COVID-19 patients. We were routing the patients through the particular fever clinics as well as the triage clinics, and the particular exit points also will be there. So it was a tremendous effort of our team, and we worked together. And for the nurses and the doctors, we were having separate accommodation facilities for them, those were treating the COVID-19 patients, and we were continuously counseling and giving special programs for motivating them. Regarding the isolation of the patients, I would like to tell you that before admitting the patients, we were considering all the patients, most of the patients as suspected patients, and we will be doing a screening session for the COVID-19. Once the result is verified, then only we will be going ahead for any planned surgeries, any procedures, and for admitting the patients. Once the patient has been detected as positive, we were putting them in particular departments. We have separated ICUs and departments for the COVID patients as well as for the suspected patients. We were turned into the gray zone and red zone. The gray zone is for the suspected patients. We will be admitting the patients in the gray zone. Once the report is readily available, then if it is negative, we will be transferring it to the normal wards. And once it is positive, we will be transferring the patients into the red zone where we are dealing the COVID-19 patients. So in conclusion, our government was very well supported us. We were having enough lab kits for testing the patients, and they were having particular guidelines and protocols. Our hospital was considered one of the COVID treating patient hospital, and we were adhering to the policies and protocols of the government, and we were going through the very smoothly. Thank you.
Thank you, Dipti. From Afghanistan, Mohammad Wais Navarad joined us, but due to poor internet connection, we lost him. So we'll now move to question and answer session or any intervention from any of you. Just raise your hand. And okay, Dr. Sulfinuhu.
Yeah, I would like to know. Audible? I'm audible?
Yeah, Dr. Sulfinuhu.
Yeah. I just would like to know the view of the panelists regarding, maybe the chances of availability of the vaccine once it is ready. We all know that it's not going to be, it will not be ready in another few months. But what is the probability of the availability even in the middle income countries and the low income countries?
Thank you, Dr. Sulfinuhu. Dr. Shrungita Misro, very briefly, please.
Yes. I'm so sorry about my internet connection earlier. I just have a very simple, I should say it's a confusion, because the lectures we learned from from other countries were like very developed and very good, well-prepared hospital. But when I looked from at a community level, when I think about my own hospital, the way we started preparing, many of our community hospitals are not at all prepared. I'm not very sure about other countries, but when I look at in Nepal, like maybe Kathmandu, like capital cities are a bit better prepared, but at local level, the smaller hospitals, they are not better prepared, where the chances of spread is much more higher, I see, because the testing facilities is very less. So can anyone suggest like how to go about it? Because in countries which are like very population where the population is quite dense, like Bangladesh, even in India, the way community transmission is happening and the way case is getting the case are rising day by day, what is your suggestion about the community management? I'm talking about the smaller units. I'm not talking about the well-prepared hospitals. I'm quite sure that many people cannot, reach those hospitals. So what is your take on it? Like anyone can answer, like how to protect our communities, especially at the smaller units, how to do about them. Thank you.
Thank you, Dr. Sangeeta. We are almost running out of time. So if you have any answer.
Well, maybe you could ask Dr.
Now I'd like to invite Professor M. Adil Khan to summarize the session. And if he has any answer for Dr. Sangeeta, he can. Dr. Adil Khan.
I certainly don't have any answer for Dr. Sangeeta, because that's something someone has done, could do it. And probably I'll ask eventually Dr. Hassan Suhag. They have actually developed a very interesting program to reach out to the community and how to address the community health units from the main central unit. But before that, let me just capture the main essence of today's discussion. And one thing I would like to emphasize that today's discussion is actually a beginning of a much longer and prolonged discussion that we will continue to have. And something like that the Center for Governance Studies and also the University of Queensland and School of Social Science would like to see is continuing. So let me just quickly share some of the things that I have learned from this today. Okay, so basically let me summarize the discussions we've had so far. First of all, what have we found out? That although the contexts, political, economic, and social contexts are different, but almost in every country, challenges have been very, very same. Because we have seen successes in both developing countries and also in developed countries. We have also seen failures in developed countries. In fact, world's richest country have been also one of the countries that have failed most in handling it. So the issues that really come up in terms of the way you succeed better is basically, to me, at a generic level, of the capacity to appreciate the nature of the problem. That's the first issue. And the second issue is empathy. You should be able to empathize with the problem, because sometimes when an issue does not hit our policymakers or our rich or elite, we don't see that's a problem. So the issue of empathy is very, very important. And consistently we have found leadership plays a very important role, whether at the national level, subnational level, or a district level. For example, Dr. Sangeeta Misra, you yourself have seen tremendous amount of leadership at a local level. You started almost from zero, and then you came from the back and you really handled it very well. For example, you flagged an issue of resources. From zero resources, you mobilized resources locally. You reached out to the international NGOs, government, donors. You created a makeshift hospital out of nothing, and you have managed it well. But then we need to do more. And that's precisely what we should be learning from others, how we can do it. In terms of community health, Dr. Sohag will tell you, although this is a model from a first world country like Australia, but I think the basic principles are the same. So maybe we'll be able to learn something from him. The second is that it's really the frontline workers, the health responders, who appreciate and understand better both the issues, challenges, and also the solutions, because they are facing it on a day-to-day basis. So this kind of dialogue among the frontline workers is very, very important. For example, some of the things that we have learned today, many of us did not even know about it, like what happened on the ground level in Kerala. They detected a situation much early in February, and they started taking preparations. So the health workers are the key, and we should be constantly dialoguing with the health for their insights. And as all of you have quite adequately highlighted, that the structures that you put in place at the hospital level is absolutely key in addressing this crisis. Like in Gold Coast Hospital, Dr. Hassan Sohag has flagged how many different kinds of instruments and framework they put in place. Like in Kerala, they have done the same thing. Also in your own hospital, others have the same thing. And the issue of safety, security, trauma, frontline responders is absolutely important. Some have been ostracized in the society. So how do you manage it? Because they're the one who are actually handling and addressing your issues at the ground level. That's one thing. The other thing that General Mainul Islam has also highlighted, the fear of among the community people. You need to educate them. And you can only educate them by demonstrating that we can address this issue. So there is no fear. We can protect the community. So once you can educate them, once you can tell them that yes, there are ways that you can protect the community, then community will be less fearful and less friendly to their health workers. And then, as you've seen, there has to be an all-encompassing governance framework, right from the central up to the local level. Because if you do not have a cohesive plan and committed plan where the resources and everything come together, then it will be very difficult to sort of handle this crisis. So what are we trying to do after this webinar? As I said, is the beginning. We are thinking of few actions after this webinar. First, we'll continue to do research, publication, and information dissemination. All of you wanted to know about vaccine. Well, University of Queensland has progressed quite a bit in vaccine. And one of the decisions the university and the Australian government has made, as soon as the vaccine is available and proven to be correct, we will share it with the rest of the world. So it will not be a property of Australia only. It will be made available to all. And finally, what I'd like to say, that together we can do so much. So what we are planning, this is what General Islam has also flagged, that we need to be together in it. COVID-19 has put us on Titanic. We are all on the same journey. We must be able to work together to get out of this crisis that we have in. If we don't, we'll all be drowned. Only difference will be some may be traveling by first class. That's about it. An interesting model of cooperation, let me flag before I finish, and which is that many people say that, well, if you are in Australia and we are in Sri Lanka or in Nepal, it's very difficult to sort of bring that technology, that knowledge into our countries. Here in Brisbane, in Australia, a unique thing has happened. The Bangladeshi doctors, we have a large number of Bangladeshi doctors working in Australia, and they have formed a group called Federation of Bangladeshi Doctors in Australia. And what they have done now, they regularly communicate with the Bangladesh Medical Association, and they exchange information on what kind of medicine they are using, what kind of approaches are they taking. So this is a kind of platform we can create. We can actually expand it to make it South Asian doctors working in Australia or in other countries, and create this kind of peer-to-peer network and dialoguing on a continuous basis. And obviously, we from the University of Queensland will be discussing with Center for Governance Studies and see how we can actually make this platform an ongoing venue or a venue for us to discuss and talk together. Before I finish, thank you very much for participating in it. I have learned a lot, and we look forward to be in touch and cooperating with you all. Thank you.
Thank you, Professor Khan. We are at the end of the webinar. For closing remarks, I'd like to invite Professor Linda Cheshire. Linda Cheshire, Head of the School of Social Science, University of Queensland, Australia.
Thank you very much. I'll keep this brief. I realise we're over time, but it really is important that we thank all of the speakers today for their contributions and insights from the front line across the world. I think everyone would agree that this has been an excellent and truly informative and collaborative event. And I'd like to echo my thanks to Zilla, Adil and Rebecca for conceiving of the idea and bringing it to fruition. But picking up on Adil's point, even as we draw today's proceedings to a close, we might remind ourselves that this is actually just the beginning of something quite new, exciting and highly promising in the research and professional practice endeavour. Not only have we been offered a better understanding of the social, institutional and deeply emotional components of frontline health work in the context of a global pandemic, but we can also get a sense of where the challenges continue to lie and where action is needed across a broad range of country and health contexts. And I think there's a lot that we can learn from each other in the weeks, months and years ahead. And each of us, researchers and practitioners alike, I think hold equally critical parts of the puzzle that can only be solved and understood through genuinely collaborative work. So in progressing this work, Adil and Rebecca will start early through the production of a short summary paper with policy ideas, which they'll disseminate widely with participants today, including the UN. And this will set the groundwork for institutional and individual conversations, ideas, and research plans, which we hope to build and strengthen in the future. And my role as head of school here at UQ is to support this work, and I do so wholeheartedly. So I'd like to thank you again today for your attendance and participation, and I very much look forward to seeing what we can create from today's events.
Thank you, Professor Linda Cheshire. Thanks to Ms. Adriana Alberti, our panelists from South Asia, Australia, and New Zealand, moderators, my co-moderator, Professor Adil Khan and Dr. Rebecca Olson, and all participants for their active participation. Let's fight together, and let's win COVID-19. Thank you very much. Good luck and good day.